Pleurisy, also called pleuritis, is the inflammation of both layers of the pleura, the parietal and visceral membranes that line the lungs and chest cavity. Remember, the parietal pleura has nerve endings, so when it becomes inflamed and rubs against the visceral pleura, the patient feels sharp, stabbing pain, especially with inspiration. Pleurisy is not a disease by itself, but a complication or symptom of other conditions. It can develop alongside pneumonia, tuberculosis, or an upper respiratory infection. It's also seen in patients with pulmonary embolism, pulmonary infarction, chest trauma, cancers, or following thoracotomy. In autoimmune conditions like collagen vascular diseases, pleurisy may also appear. The hallmark clinical manifestation is pleuritic pain, that sharp, knife-like pain tied directly to respiratory movement. Patients describe worsening pain when they take a deep breath, cough, or sneeze. It usually affects only one side and is limited in distribution rather than diffuse. Sometimes it radiates to the shoulder or abdomen. Interestingly, if the patient holds their breath, the pain often subsides. As pleural fluid accumulates and separates the inflamed surfaces, the pain may actually decrease. On assessment, early in the process when there's little fluid present, a pleural friction rub can be heard with a stethoscope, a rough, grating sound during inspiration and expiration. Once more fluid builds up, that sound may disappear. Diagnostic testing can include chest x-rays, sputum studies, thoracentesis to sample pleural fluid, and occasionally pleural biopsy to determine the underlying cause. Management of pleurisy focuses on two objectives: treat the underlying condition and relieve the patient's pain. If the inflammation is due to pneumonia or infection, treating the infection will usually resolve the pleurisy. During this time, patients must be closely monitored for signs of pleural effusion, shortness of breath, decreased chest wall movement, or adopting a position that lessens discomfort. Pain control is essential. Analgesics, heat or cold applications, and NSAIDs can all provide relief and allow the patient to breathe deeply and cough more effectively. Without pain relief, patients often take shallow breaths, increasing their risk for atelectasis or pneumonia. In severe cases, an intercostal nerve block may be required. From a nursing perspective, our role is to help reduce discomfort and encourage strategies that make breathing more tolerable. Turning frequently onto the affected side helps splint the chest wall, reducing stretching of the pleura. Teaching the patient to use their hands or a pillow to splint the rib cage while coughing also helps manage pain. Comfort measures like these not only ease symptoms, but also support recovery by encouraging effective ventilation and secretion clearance. The takeaway is that pleurisy is painful, but with careful assessment, treatment of the underlying cause, and appropriate nursing support, patients can achieve relief and avoid complications.